Can you answer the questions correctly? Find out in this activity that is customized to you. Test your current knowledge with the series of questions related to the topic and rate your confidence for each answer. If you answered correctly and were confident, you will move on to the next question. If you need a little more information about the topic, an expert will provide evidence that supports the most appropriate answer choice. Then you will have the opportunity to try again with a similar scenario. When you have finished all of the questions, a summary page with your results will be provided, along with links to all of the expert presentations for your reference. Earn credit by answering the review questions at the end. Let's get started. The following podcast is part of a certified educational activity titled Leveraging the Power of Targeted Biologic Therapy in Severe Asthma. Do you know how and for whom? Access the entire activity and complete the post-test at peerview.com/PRN860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Jeffrey Chupp from the Yale School of Medicine in New Haven, Connecticut. Welcome to this unique activity that will explore the use of targeted biologic therapy in severe asthma. Joining me today is Dr. Autumn Burnett of Howard University Hospital in Washington, D.C.
Thank you. So glad to be here with you, Dr. Chupp.
Before we begin, let's start with a brief look at where we are in the treatment of severe asthma and what some of our current challenges are. The goals of asthma management are to reduce current impairment and reduce future risk. To do that, we improve symptom control in patients, which includes daytime symptoms and nocturnal awakenings, and we manage comorbidities that can affect asthma, and we work to improve lung function. We also focus on reducing exacerbations and the need for systemic steroids, the reduction of rescue medication use, treatment of related exacerbations, and we try to reduce visits to the ER. And we recognize that this is a partnership with our patients, and it requires shared decision-making to achieve these treatment goals. Now, asthma is a heterogeneous disease, and we need to recognize that patients respond to therapies differently. And this has resulted in an increased understanding of the complex pathophysiology of the disease and the fact that there are biologic endotypes that underlie this heterogeneity. And this drives the different clinical phenotypes that we see when we evaluate patients. We also have learned this from the development of biologic therapies, of which there are now 6 available in the clinic. And these are outlined here on this slide. And what they can do in severe asthma is really tackle the challenges of control that I outlined in the earlier slide, which is reduce exacerbations, reduce systemic steroid use, improve quality of life, and improve lung function. So GINA guidelines have really embraced the fact that we need to focus on these goals and that biologic treatment should be considered for patients who are on high-dose therapy, step 5, and remain uncontrolled. And these patients need to be phenotyped properly to determine what is driving their disease, what comorbidities are contributing to their disease, what biology is underlying their disease. But it's important to recognize that with 6 biologic agents available, it can be challenging to determine which patients are candidates for which biologic therapy and what is going to be best for the patient from both the physician's point of view and the patient's point of view. So our goals for today are to expand your knowledge of the relationship between asthma and other conditions driven by type 2 inflammation, enhance your skills at identifying pediatric and adult patients who may be candidates for targeted asthma therapy, and improve your ability to integrate biologic therapy into individualized asthma management plans.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/PRN860.
So now I'm going to hand it over to Dr. Burnett to discuss the biology underlying the complex disease of asthma.
Thank you, Dr. Chubb, for that introduction on asthma and how we are introducing the conversation about choosing biologics. I will now get into the conversation about type 2 inflammation in terms of its activation, the tissue effects, and the downstream effects that happen in this process. Essentially, there's an epithelial barrier, whether that be in the upper airway, the lower airway, the skin, or the gut. This can be driven, if you will, by alarmins. It can also be driven by adaptive immune responses. We know that there is a shift in terms of naive T cells into Th2 cells, which release important type 2 inflammatory cytokines such as IL-4, IL-13, and IL-5. We also know that alarmins can help drive this immune response as well. When that happens, there are symptoms that occur as a result of the cytokines that are produced. We know that itch is involved. We know that there can be the production of IgE via isotype class switching of B cells via the influence of IL-4 and IL-13. We know that eosinophils can be trafficked into tissues from the blood. We know that these cytokines can influence collagen deposition. We also know that IL-13 plays a huge role in fibroblast invasiveness as well. We know that IL-13 can be involved in goblet cell hyperplasia, metaplasia, and mucus secretion. We also know that IL-5 plays an important role in localized inflammatory responses after its differentiation in the bone marrow. Again, here we see some of the key cytokines involved in type 2 inflammation, which include IL-4, IL-13, IL-31, and IL-5. And some of the primary immune cells that may be involved are listed here as well. Some of the inflammatory subtypes of asthma are shown here. We know, and Dr. Chubb mentioned this before, that we are now starting to really think about the phenotypes of asthma as we think about type 2 inflammation, which can involve eosinophilic asthma, allergic asthma, or a mixed picture. We know that there is also a neutrophilic or granulocytic asthma that is a completely different phenotype. We know that this involves, again, the heterogeneity of asthma. There's certain biomarkers that we can obtain from sputum, bronchoalveolar lavage, biopsies. We know that those important biomarkers in terms of identifying type 2 inflammation can include fractional exhale nitric oxide, blood eosinophils, and IgE as it pertains to allergic sensitization. We oftentimes talk about the endotypes of asthma, which can involve type 2 inflammation or what we call T2 high endotype, or a non-type 2 process, which is what we call T2 low endotype. If we talk about T2 high asthma, we most often associate that with an immediate IgE-mediated allergic reaction or eosinophilic inflammation, or even IL-13-mediated production of nitric oxide. And we also think about T2 high asthma in terms of asthma being responsive to corticosteroids. Multiple patients fall under the type 2 asthma umbrella. And again, you can see these biomarkers here, IgE, fractional exhale nitric oxide, and eosinophils, which can actually lead us to certain types of, if you will, asthma patients who may have either early onset asthma, they may be responsive to steroids or less responsive to steroids, or it may even involve a late onset type of asthma, which may be more indicative of eosinophilic type of disease. There's actually no single biomarker that captures the full range of type 2 inflammation in patients with T2 high asthma. They can have a mixed picture as well. But it is nice to see here that, type 2 asthma can fall under this global general umbrella. In terms of T2 high asthma, again, there's an early onset which takes place pre-adolescence, and this involves mostly atopic and allergic asthma phenotype patients. Here we would have a strong family history of atopic disease. T2 high asthma typically may overlap with other comorbid atopic conditions such as allergic rhinitis and atopic derm. And essentially, patients with T2 asthma may present with either mild, moderate, or severe disease, and they can have a variable course. And this asthma can be exacerbated by obesity. If we look at the later onset eosinophilic asthma phenotype, which is still considered a T2 high asthma, taking place in predominantly patients after the age of 20, approximately 50% of asthma is associated with high eosinophils in this particular category. Greater than or equal to 2% eosinophilia can be identified in the sputum, or patients may have greater than or equal to 150 to 300 eosinophils found in the blood. Eosinophilia in these patients can persist despite inhaled corticosteroid treatment. And typically, these patients may have a variable allergic status. Often severe from the outset is indicative of this eosinophilic phenotype asthma. And oftentimes, these patients can have sinus disease, polyp formation, and aspirin sensitivity, or AERD. And oftentimes, this particular T2 high asthma that is eosinophilic phenotype can be exacerbated by or associated with obesity. So now let's take a look at the downstream effects after that amplification phase. Here we get the maladaptation of what happens when those immune responses take place and the inflammatory cascade takes place with the influence of those T2 cytokines, IL-4, IL-13, IL-5. Again, you can see there may be tissue disease and associated diseases that is associated with this inflammatory cascade. In eosinophilic esophagitis, we can see inflammation in the esophagus along with narrowing and symptoms of dysphagia. In atopic dermatitis, we can have skin thickening and inflammation and a chronic itch, which may be influenced by the cytokine dysregulation. And in asthma, there can be airway hyperreactivity, there can be obstruction, smooth muscle contraction, all as a result of the inflammatory cascade from these cytokines. Atopic dermatitis is postulated as the first manifestation of the atopic march. This often precedes the later development of food allergies, asthma, and allergic rhinitis. And you can see this proposed model where eczema and food allergy rise first and then slowly kind of taper after the age of 5. You can also see a slow rise in the wheezers, which then ramps up between the age of 3 and 5 in terms of asthma, and then it kind of slowly drifts off in adolescence, but it still kind of has an effect on patients into adulthood. And then we can also see that rhinitis begins after the age of 5. It will ramp up between the age of 5 and 10, and then it will kind of plateau off in adulthood. Type 2 inflammation, we know, shares a relationship with asthma, but other common comorbidities. Type 2 inflammation and the shared relationship between asthma and comorbidities is shown here. You can see there can be allergic rhinitis in patients with asthma, along with food allergy, atopic dermatitis, chronic rhinosinusitis with nasal polyps, eosinophilic esophagitis, COPD with type 2 inflammation, chronic spontaneous urticaria, bullous pemphigoid, and prurigo nodularis. Type 2 inflammation hallmarks, again, include increased type 2 cytokines and chemokines, such as TARC and others. Also, eosinophils, basophils, mast cells, innate lymphoid cells type 2, IgE levels, and barrier disruption are all involved in terms of the hallmarks of type 2 inflammatory disease. Type 2 inflammation occurs systemically but can present with many different local tissue manifestations, as shown here.
So let's discuss a case of a patient with severe uncontrolled asthma. Here's Scott, a 33-year-old gentleman, presents with asthma that remains uncontrolled. Baseline findings when you evaluate the patient in summary are that he's on high-dose ICS-LABA, so GINA step 5, and he's had 2 exacerbations requiring systemic steroids in the year before arriving to your office. Clearly an uncontrolled patient. So the question is, what would you do now? So it's become pretty clear that there's a algorithm we go through when we see a patient like this. And the first step is to really get a good history on the patient, make sure you understand their asthma history and how they became severe. What was the process? Are they an early onset atopic patient or a late onset eosinophilic patient like Dr. Burnett has presented? And then what you do once you sort that out is you decide what additional testing is important to get on the patient so you can determine if there are other diseases that are contributing to the patient's severity and other workup that needs to be considered. So here on this slide, you can see additional testing that can be considered in these cases, not always all at once, but perhaps over time. An exercise challenge, high-resolution CT scan to look for bronchiectasis and air trapping. We consider bronchoscopy in patients to look for indolent infection that could be driving their severity, and get induced sputum as well and test that for bacteria. And we often will give a course of steroids to see if they are responsive because, as Dr. Burnett mentioned, this can help you understand if this is a T2 high type patient. You treat comorbid conditions such as GERD, allergies, sinus disease. These are the big 3 that you have to consider and manage carefully because they can mimic severe asthma as well as aggravate severe asthma. And you have to consider the patient's environment. Are there pets in the home? Is there a dusty environment? Does the patient have an occupation that's driving the severity of their disease? And modify it as much as you can, because of course it's always great to modify the environment and make your patient better without having to give them a medication. So once you go through this algorithm and you determine if a patient is truly severe as opposed to difficult to treat, you then explore a few other things such as anxiety and depression and ability to take their medications due to access or general noncompliance or disbelief in the medications. And after you sort that out, you really come to the point where you recognize this patient has truly severe resistant asthma, or what we call refractory asthma in our center. And at this point, you need to really dive into the patient's phenotyping and understand their disease, because at this point, you're likely to choose a biologic therapy to improve control of their disease. So in this situation, the standard phenotyping now, which has changed over the last 20 years, is that we do a CBC to look for eosinophils. We do IgG in subclasses to check for immunodeficiency, high-resolution CT scan to look for bronchiectasis, as I mentioned, allergy testing either by blood or skin prick testing, and we determine if the patient is allergic and has that exposure in their environment. We look for asthma variants such as ABPA with ABPA titers, or EGPA with an ANCA, which is rarely positive, so the history is important to do a full review of systems and make sure the patient doesn't have neurologic symptoms or rashes that could increase your suspicion of EGPA. And at that point, we evaluate the data that returns, and we determine what the best therapy is for the patient. The one thing that's not listed on this slide is the lung function testing, which of course we do full PFTs with lung volumes and diffusion capacity and an exhaled nitric oxide level, as well to look for evidence of eosinophilic airway inflammation by monitoring the amount of exhaled nitric oxide being produced. So we generally consider a patient eosinophilic or high type 2 if they're severe and uncontrolled and have blood EOs above 150 cells per microliter or an exhaled nitric oxide level above 25 for adults or above 20 parts per billion for children. And it's important to recognize that these values vary, and so you have to test them over time. Recommendation is on the slide. You could see several times to confirm a patient is elevated, but I think what's important here is that you just test the patient a few times. If a value is low, that doesn't mean the patient doesn't have type 2 inflammation. You may have missed it because they were recently on systemic steroids. Some centers do sputum eosinophils. This is generally not done in the US. Or asthma that is clinically allergy driven. These are all markers of type 2 high disease. So, as was mentioned, we confirmed the diagnosis of asthma. We evaluate adherence, manage comorbidities, phenotype the patient for type 2 inflammation, and then we determine the biologic therapy patient's best to receive. So I'm going to hand it over to Dr. Burnett to discuss a pediatric case of uncontrolled asthma.
So this brings us to Emma, who's an 8-year-old with uncontrolled asthma. Baseline findings were that she was diagnosed with asthma at the age of 6 years old. She's currently on high-dose ICS/LABA. She's had visits to the emergency room and 4 courses of oral corticosteroids in the past year. Her comorbidities are allergic rhinitis and moderate atopic dermatitis, biomarkers that indicate that she possibly has T2 inflammation is that her FeNO levels are above 20 parts per billion. What do we do now for Emma? So the GINA gives us an approach for how we think about the treatment options for patients that are children aged 6 to 11 years of age. And obviously, we're going to do those assessment things that Dr. Chupp mentioned, which is confirmation of the diagnosis and ruling out comorbidities and making sure patients are adherent to therapy. But then we're going to look at our step 1 through step 5 treatment approaches in terms of how we think about this patient. And we know that if patients have already reached higher dose ICS/LABA, they're really at that step 5 plateau, if you will, or in terms of the GINA guidelines. And so at this point, short courses of oral corticosteroids may be needed for patients presenting with severely uncontrolled symptoms. However, this is the step where we essentially want to really truly refer for phenotypic assessment and consider adding on additional therapy that is not a systemic corticosteroid, such as a biologic treatment. There are other controller options to consider at step 5, which would be a last resort, considering, again, that oral corticosteroid. And reliever therapy, we know in GINA steps 1 through 5, is as needed short-acting beta-2 agonist, which can be either ICS formoterol reliever, and there's also an alternative track for GINA as well. Given that Emma is allergic, she has atopic dermatitis and has elevated FeNO levels, anti-IL-4, IL-13 therapy may be the best choice for Emma. Let's now take a look at some of the clinical trial data that supports using dupilumab for Emma and her asthma. If we look at the long-term efficacy and safety of dupilumab in children with asthma from the Liberty Asthma Excursion Study, we can see 365 of 408 children with moderate to severe asthma from Voyage, which was that main pivotal trial for this pediatric population, enrolled in Excursion, which was a 52-week-long open-label extension study primarily looking at safety measures. As you can see, the exacerbation rate reduction was higher in the dupilumab patients versus placebo, in that 52-week Voyage study, you can see excursion being that primarily safety study, not primarily looking uh, at exacerbation reduction. You can see that those levels still remain low in terms of exacerbations in these children with moderate to severe asthma. The long-term treatment was well tolerated with an acceptable safety profile in the Voyage and excursion studies. I'm now going to hand it back over to you, Dr. Trepp, to discuss another severe asthma case.
Thank you, Dr. Burnett. Let's talk about Julie, a 30-year-old woman confirmed to have severe asthma. Her baseline findings at your evaluation are she's on standard maximum inhaled therapy, and she has elevated eosinophils and an elevated FeNO level. So she's what we like to call a hot patient because she has both eosinophilic inflammation that's likely driven by IL-5 pathway activation, as well as a high FeNO, which suggests that she's got an activated IL-13 pathway as well. So either a anti-IL-4/13 or an anti-IL-5 receptor therapy are good options for this patient. So how do you choose which of these drugs is best for Julie? Well, as you can see by the boxes on this slide, it's a fairly complicated process that you have to go through to make that decision. And it revolves around the patient's characteristics. We generally think about IL-5 therapies for patients that have predominantly eosinophilic inflammation, but in patients like Julie, they could be a candidate for either. You have to consider patient preference, both based on what you tell them about the drug and its mechanism and the clinical trial data, and also based on the practical side of the drug, how often it's dosed and what the known side effects are. The route of administration is all the same for these agents now, except for reslizumab, which is not really used that much because it's IV and there are other options. Cost, of course, is a major factor for patients and has to be considered based on the type of insurance they have and whether they want to receive it in the office or do auto-injection at home. Comorbidities is critical because a number of these agents have multiple indications, such as dupilumab, which is indicated now for asthma, nasal polyposis, eosinophilic esophagitis, and they have excellent data now in COPD that suggests that approval could be coming soon. And your experience as a clinician with the drug in terms of its efficacy in patients, as well as the long-term safety profile, like Dr. Burnett showed with the excursion data. And then, of course, adherence is critical as well. If a patient needs to be in an environment where they're going to be compliant to use the drug. So as you can see by GINA, there are multiple options and a complex algorithm that you go through to choose each of these drugs based on the inclusion criteria and the biomarkers that were used to select patients for the phase 3 trials. IgE patients were all allergic, so they had to have positive RAST or allergy tests. IL-5 patients had EOs that were above 150 or 300 at the time of entry into the trial. Anti-TSLP patients or all comers, they were used in all of those patients, in all patients regardless of their baseline biomarker, and was shown to be effective. An anti-IL-4/13 receptor therapy was also shown to be effective in all comers, but ultimately in subgroup analysis was shown to be more effective in the higher eosinophilic patients. So its indication is for those patients that are eosinophilic. Uh, Special considerations are also outlined here on this slide. You can see there's a lot of overlap between the given therapies with a few exceptions to avoid uh, live virus vaccines, depending on the clinical trial data. But generally, side effect profile and safety are similar with these agents. So I'm going to hand it over to Dr. Burnett to discuss our last case.
Thank you, Dr. Chubb. This is Dan. This patient is a 45-year-old male with severe asthma who is currently on biologic therapy for asthma. Baseline findings and treatment is that he is on a standard maximum inhaled regimen in addition to his biologic therapy. So we're assuming he's at GINA step 5. There's been little improvement, however, after 8 months of being on his current regimen. He continues to have persistent symptoms. How do you proceed at this point? So, a couple of things. One, this particular GINA information shows us that it is important once a patient is on biologic therapy, not only do you assess them in just in terms of the efficacy and the safety of the drug, but you actually should monitor their and assess their response to that biologic therapy at intervals. So essentially, you can make a choice at the onset of which biologic you may choose, and then continue to reassess. And if the patient has a good asthma response, then medication can be continued. But if a patient is not getting the optimal response, stopping that therapy and considering switching to a different type 2 targeted therapy if that patient is eligible. And again, here, that trial in this particular assessment here should be at least for 4 months of being on a biologic before you can really truly assess a response to the drug. So, if a patient has a good response to type 2 targeted therapy, you can reevaluate that patient at routine intervals every 3 to 6 months. If a patient is on oral treatments, you can consider decreasing or stopping, let's just say, oral corticosteroids first, checking for things such as adrenal insufficiency, and then stopping another add on medication. For someone that may be on an inhaled treatment for asthma, you can consider decreasing after 3 to 6 months in terms of that load of steroid of that inhaled treatment and continue at least a moderate dose of ICS LABA for that patient if they are showing a good response to targeted biologic therapy. And then again, reevaluating the need for ongoing biologic therapy. In terms of uh, patients that are not having a good response to biologic therapy, you can consider stopping that biologic therapy and reviewing the basics. Differential diagnosis, making sure you got the diagnosis correct and the patient is not suffering from another comorbidity. Assessing for inhaler technique and adherence, looking at side effects that may be involved with the biologic, and providing emotional support for that patient. Also, you can consider doing other testing measures, such as looking at high resolution chest CT and reassessing phenotype and treatment options. Again, considering other modalities of assessing for disease, such as induced sputum. Consider adding on low dose azithromycin. Consider bronchoscopy or other alternative additional diagnoses. And as a last resort, consider adding on low dose OCS, but implementing strategies to minimize side effects and long term use. And so, this is essentially how one would respond if the patient is having a good response to biologic therapy and how a provider would respond if one is not having a good response to biologic therapy. In summary, considerations for switching biologics, again, we would look again at that pheno-endotype assessment and our baseline biomarkers, IgE, blood eosinophils, fractional exhaled nitric oxide, and the change of those biomarkers over time. We can look again and assess the specific target that we want to consider for someone's specific phenotype and endotype. We can assess comorbidities to make sure that we're managing those accordingly. Not only that, we can consider if Some of those comorbidities may be also involved with a type 2 inflammatory response, such as chronic rhinosinusitis with nasal polyps or eosinophilic esophagitis or gastritis. We can also assess for other comorbidities that may involve eosinophils, such as hypereosinophilic syndrome and EGPA. We can also discuss through shared decision making a patient's preference in terms of frequency and route of administration and cost, and then looking at their overall clinical response in terms of exacerbation rate reduction, their use of oral corticosteroids. Are they still having exacerbations that require systemic steroids? Their level of control through measures such as an ACT score or an ACQ score, and obviously things like lung function, which help us as a parameter for assessing improvements in their overall clinical response.
Thank you so much for joining us, and I hope you found this program to be useful as you continue to care for patients with severe asthma. And thank you, Dr. Burnett, for being here and contributing your insights to the discussion and outlining how to treat patients with severe asthma.
Thank you, Dr. Chubb, and thank you all for attending this CME.